It's called the silent killer. There are no noticeable symptoms. It can lead to stroke, heart attack, and heart damage. How to manage your blood pressure and avoid a stroke. That's today on Time Waits for No One.
From St. Vincent Mercy Medical Center with Dr. Ameer Kabour, Chief Cardiologist and President of Toledo Cardiology Consultants. This is Time Waits for No One. Today, high blood pressure. You may have it now and not even know it. Worse yet, it can lead to stroke, heart damage, even death. Understanding and controlling your blood pressure. Plus, carotid artery surgery with Dr. Gregory Kasper. And the newest treatments for stroke victims from Dr. Eyal Morag. That's today on Time Waits for No One. Sponsored by The Blade.
Hi, thank you for joining us again. Today we are going to concentrate on two subjects. The first one is related to hypertension or high blood pressure. The second one is going to be about stroke. There is a lot of information to understand and to comprehend, and we're going to take you step by step to understand both problems. We're going to talk to some experts regarding this issue. At the same time, we're going to show you some animation to make your understanding as simple as possible. Any one of your family members has a high blood pressure? I'm sure you heard that term. High blood pressure harms multiple organs in our body: the heart, brain, kidneys, and eyes. The first heart sign for blood pressure is thickening of the heart muscle, leading to struggle in pumping blood to the circulatory system. Over time, blood pressure could lead to hardening of the arteries and building blockages and narrowing the arteries in your heart. When that narrowing reached to the critical point, that could result in a heart attack, leading to a permanent damage to your heart and may result in a heart failure. Blood pressure or hypertension is the leading cause for kidney failure. It affects the capillaries or the small vessels in your kidney, leading to breakdown. Damaging those vessels in your kidney will affect the ability to filter and clean blood, and if left untreated, will lead to failure, and subsequent to that, you could end up on dialysis machine. One of the other major complications for hypertension or high blood pressure is to affect the arteries in your retina, in your eyes. That will lead to bleeding or blockages, which could lead to blurred vision or loss of your vision. The most devastating complication for hypertension or high blood pressure is stroke. As you know, high blood pressure is #1 cause for stroke in the United States. The reasoning for that high blood pressure will lead to hardening the arteries, which could lead to one of two possible complications. The first one is blockages in the arteries, which lead to shutting down the circulation in a small portion or part of your brain, leading to the stroke symptoms, which is probably you saw some of the patients having weakness in their left arm, left leg. The second possible complication is rupture in those arteries, leading to hemorrhage or bleeding in the brain, which is also will lead to similar symptoms called stroke. Hypertension is the silent killer. It's #1 killer in the United States when we look into the complication produced by the hypertension. You need to remember that the normal blood pressure, as advised, is to be less than 120/80. 120 is the higher number, 80 is the lower number. When you get to the blood pressure more than 140/90, that means you are at higher risk for stroke, and that will increase your chance by about 40 to 50%. If you are diabetic, your number should be different. The higher blood pressure than 130/80 considered higher risk for stroke. So you need to understand how important as a diabetic patient to have a lower blood pressure than the person who is not diabetic. Why we called hypertension silent killer? Because many people, they have a high blood pressure and they don't know. In general, you need to check your blood pressure when you go to your family doctor, but also if you have a family history, if you are overweight, if you have heart problems, if you are diabetic, you need to remember that probably you are at higher risk to have a high blood pressure, and you should check your blood pressure on a regular basis. The bigger question, if you are diagnosed with hypertension or high blood pressure, what should you do about it? There's few steps. We're going to call it the 5 steps treatment. The first one is to reach a healthy weight. Your weight is so correlated with your blood pressure. If you are able to lose weight, you are already reducing your chance of having a high blood pressure significantly, but also if you are hypertensive, you are going to lower your blood pressure without medication. Number 2, if you drink alcohol, to drink less. There is a good relationship between drinking alcohol and high blood pressure, and that's why we recommend to drink less. The third one is to eat healthy, to get less salt and sodium. And that's why you need to watch your sodium intake, and also to pay attention to the salt you are using on a regular basis. The fourth step is to be physically active, which is probably the most important step, because the more activity and the more exercise, you're going to lose weight and you're going to have a better blood pressure control. And number 5, when all of these steps are not working and doing the job, you need to talk to your doctor, because I'm sure your doctor is going to recommend some medication. But probably the more important thing is to be compliant and to follow your doctor instruction and to take your medication exactly the way he tell you, not the way you think, because this is so important to follow to avoid major complication, as we showed you previously, from the hypertension or high blood pressure. Now, after we talked about hypertension, let's talk and discuss stroke, which is a major complication, and show you the details, how is the stroke happening. And also, we are going to talk to one of the experts who really going to help us and guide us step by step, how we could manage the stroke when it happened at the right time, appropriately, to avoid having the major complication of losing our control on our body. Welcome back. Today, we are going to finish our discussion about the stroke. And as you remember, we had the concept of dividing the stroke between ischemic and hemorrhagic, or the bleeding stroke. And we have one of the experts who is an interventional radiologist to discuss those options of treatment with us. Today, it's my pleasure to welcome to the show Dr. Morag. Welcome.
Thank you very much.
So really, we want to use your expertise to tell us in a simple way about the best treatment possible these days for the stroke patients. You know, we are trying to tell the patients to rush to the hospital as fast as possible because of the new studies which is suggesting that the sooner you get to the hospital, the better the treatment we get. So would you just summarize those treatments from your standpoint?
Right, so I just want to emphasize, as you mentioned before, that we, for most part, we talk about the ischemic strokes, which affect approximately 90% of the population. And as far as the options that we have for treatment these days are all included in what we call the minimally invasive approach, where we basically treat the patient through a little opening in the groin in a very similar way to what the cardiologist will do for the heart and the vascular surgeon for other parts of the body, and we basically insert a catheter within this critical time period that we all kind of discuss and know, between 3 and 6 hours. Mm-hmm. Where we put that catheter in a selective way into the artery that is occluded. I mean, that stroke is caused by occlusion of an artery. And the purpose, obviously, is to open this occlusion and basically get the blood back to the brain, to the area that is affected. So we have several options. The most common one would be opening this narrowing with a balloon, again in a similar way that's done in other parts of the body. Sometimes we need to support that with a stent, which is this metallic scaffolding that is used also in other places. And often we will put the catheter after we open that occluded segment next to the affected area and infuse solutions that can dissolve clots. The other option we have is actually to suck that clot out with a special mechanical, we call it mechanical thrombectomy device, which is basically a mechanism at the end of the catheter where we can put the catheter next to the clot and suck it out.
Sure.
Those are the main.
So why we can't do the same thing after the 6 hour? We always emphasize on the benefit between 0 to 6 hours as the best benefit for the patient and the best outcome. So what about if after 6 hours, why we don't do the same to them?
Well, you know, research has shown, and it's known that there is an exponential increase in the degree of death of brain cells as time goes by. So, you know, the efficacy of doing this after the time period that we're talking about is much lower. So you're not actually saving the brain from that point on. What we would like to do is you know, be able to affect the area that is still not dead, or what we call the penumbra in the medical terms, and make sure that that area is reinfused with blood shortly after the stroke. The longer you wait, the worse the outcome.
Absolutely. What about the other 10% or 20% of the patients who are coming with hemorrhagic or bleeding? Do we do the same to them, or is there some different alternative we should use?
No, so those 10%, that approach to that 10% is different because the underlying cause is different. So usually the most common cause of a hemorrhagic stroke is either a hypertensive hemorrhage, so it's an active bleed from basically breach of the normal structure of the vessels from high blood pressure, or a ruptured aneurysm, which is this saccular dilatation or this outpouching of a blood vessel within the brain that ruptures. And in that case, you know, you want to stop the bleeding by blocking these areas. So the most common procedure that is done is releasing what we call a coil, which is basically a kind of a long metal wire, like a spring-shaped wire, that is in a control way released within that saccular dilatation of the vessel, with the idea of basically blocking it and forming a clot within that aneurysm that will eventually result in you know, preventing the hemorrhage from continuing.
And that's where really we emphasize to the patient how important, as soon as they start feeling some kind of strange symptoms, could suggest possibility of stroke, just immediately to ask some of their relative to take them to the emergency room as soon as possible, because the activation and the sooner, as we emphasize on, the sooner to interfere in managing those patients, the better the outcome. And trust me, no one of the patients will love to be a patient who suffered of stroke, because the consequences is devastating. I really want to thank you and appreciate your expertise. And he is really came in town recently, and we are happy to have him. And I'm sure it's going to improve also the quality of care we have in our community, which is really our goal, as we emphasize always, to take care of our patients in our community. And I appreciate it so much.
Thank you very much.
And that's why you decided to put a stent for this patient as the best option for it. Yes. And that's what we're going to show in a few minutes, how Dr. Kasper is going to introduce that stent for this patient. And hopefully we will discuss later the possible complication of the procedure and the benefit on the long run and the follow-up for that patient. Welcome back. It's my pleasure to have Dr. Greg Kasper, who is the Chief of Vascular Surgery in Mercy St. Vincent Hospital, to discuss the follow-up for the stroke patient as we discussed before. Now, the point which we are trying to discuss today is related to the carotid disease. Greg, welcome on our show.
Thank you very much for having me, Ameer.
We presented some examples about stroke patients, and you know, one of the elements about the etiology and the reasons for stroke, and one of it is related to the carotid stenosis, which is, you remember, it's a blockage is bending up in those carotid big vessels, could lead to the stroke. And you know, we're going to show some examples of your patients where you're doing a tremendous and very successful procedure. Would you give us some information about the relationship between the carotid disease and the stroke? How frequent? What is the best modality to diagnose it, and how to treat it?
Exactly. Everybody has 4 blood vessels that take blood flow up to the brain. As you know, and the 2 carotid arteries that go up in the front of the neck do most of the work. At about the angle of the jaw, they split, and they give off a branch that supplies the muscles of the face, and the other branch goes straight up to the brain. And it's very common to get some buildup of plaque in that area, typically from smoking, high blood pressure, high cholesterol, diabetes. Genetics play a role. We see that in aging. The same risk factors you see in cardiovascular disease make patients prone to this as well. And what can happen is significant narrowing in that area can lead to what we call embolization, which is a piece of plaque or clot breaks off and travels upstream. It can lodge in the brain and the patient loses function of that portion of their brain, and that can be a significant and devastating stroke at times. Simple way to look for it, a lot of times physicians will listen and they may hear turbulent flow in the carotid arteries. We call that a bruit. If they hear that, then it alerts them to go ahead and check an ultrasound. And a simple ultrasound is a non-invasive test, no needles, no drugs, doesn't require anything invasive, and that can give us a good idea if there's significant plaque going on there and if we need to take further measures.
Now, when we are talking about those ultrasound or Doppler ultrasound for the carotid, and we get different reports, if there's any idea, because we always give the patient some percentage. Do you mind to tell us the details of those percentage?
No,
I mean,
exactly.
when they should be curious and interested in follow-up with the vascular people to decide about treatment?
Exactly, great point. And we do those very commonly. A lot of the primary care physicians do that regularly, and I know we both do as well. And typically, ultrasound can give you a range. It can't tell you exactly how narrowed something is. Typically, the ranges will be 0 to 15%, 16 to 49, 50 to 79, 80 to 99, or 100%. And certainly more concerning if it's in the 80 to 99% range, and that's someone that needs to be evaluated and treated, within the next few weeks. If it's in the 50 to 79% range, then that's usually when we say some evaluation by a vascular professional or vascular specialist is going to be warranted to help delineate exactly where they're at in that range. More towards the 50% range of narrowing is very safe, not very much risk, but needs to be followed perhaps every 6 months with repeat ultrasounds. When you get up more towards a 75 or 80% narrowing, that's when you need to consider other risk factors and say, how dangerous is this and what can we do to help reduce that patient's risk of stroke long term?
Saying all of that, also, if we have a patient questionable, like less than 49%, and they have symptoms, they should not take that as a percentage, as a solid. We should do further evaluation, like when we tell them to go and see you guys, to do the angiogram to be accurate, because those ultrasound not 100% accurate. Is that the case?
You are exactly right. And I think if you've got a patient that's asymptomatic and it's less than a 50% narrowing, you're pretty safe in watching them. But if they're having symptoms and you're concerned, and you can look at the ultrasound a little more closely, and that's something that certainly someone who interprets vascular studies can do, to see if the plaque is very irregular, if there's what we call ulcerations. Mm-hmm. I always tell patients an ulceration is like a pothole, and what do you tend to see in a pothole? You see gravel, so there can be loose debris. So that can be a dangerous sign too, of plaque that's not significantly narrowed, but has some significant factors that need to be evaluated further.
And if we find the patient have significant symptoms and significant blockage by the Doppler ultrasound, and you confirm it now, would you summarize to us the treatment? I know that there's 2 approaches, and probably you need to give us some information about it.
Yeah, if it's a significant narrowing and there's a significant risk of stroke to that patient over the next 3 to 5 year period, then we might do some intervention to reduce that risk of stroke. And the 2 interventions are typically an angioplasty or stent, or carotid surgery, where we go in, make an incision on the neck, and clean that plaque out. So different risk factors for the patient would determine what may be best for them. And there's risk factors and risks of stroke with each of those procedures. So that's why we're not operating on every patient with carotid disease, and we're waiting until the risk of the surgery or the procedure far outweighs the benefit.
What about medical treatment? I mean,
It's
what
far
is the
less than
best
that.
option other than taking aspirin? If there's any other modalities usually or medication you advise the patient to take?
Certainly, it's just like we talked about the risk factors. The most important thing is quitting smoking. I mean, I can't emphasize that enough. I know you do that, and we talk about that daily with patients. That's the most important factor. Controlling blood sugars if they're diabetic, controlling blood pressure for hypertensive patients, watching cholesterol, all those are going to be the important factors. Typically aspirin, other medications to help control cholesterol, diabetes, or high blood pressure, and occasionally we'll add Plavix to the mix as it's a little bit stronger of a blood thinner than aspirin.
And the carotid surgery is the most commonly used to take that plaque out probably, and the most recommended procedure in general. We know that we do the stent the way we are going to show later, probably some examples about one of those procedures which you did earlier. So the carotid stenting, who we should recommend it at this point to?
Which patients? Typically, it's best performed and safest on patients that have had either previous carotid surgery, have had radiation to the neck, which leads to a smoother scarring of the artery, so it's less risk when we do put the stent in place, or patients that are too high risk to undergo the surgery. And there are a significant number of patients, obviously, with carotid disease that have significant coronary artery disease as well, and some of those patients are going to be good candidates for stenting.
So the bottom line, it's not the first line of treatment. We always been asked, should we, like, am I a candidate for a carotid stent? We should answer the question that only as a last resort.
Typically, that's exactly right. If patients are able to undergo the surgery in a safe manner, that is the safest procedure as far as reducing their risk of stroke.
After we talked about high blood pressure, what we call hypertension, now you are aware about the risk, about how we should manage it. Don't be one of those patients who did not follow the instruction and take care of themselves and end up with a big stroke. I don't have to tell you about one of my patients who is in the 30s, young gentleman who lost his left side of his body, arms and legs, unable to walk and unable to talk, just because he did not follow the instruction his family doctor insisted on to take his medication and treat his blood pressure, assuming that his blood pressure is okay when he checked it once and it was okay. You need to have a strict follow-up with your family doctor. He is the captain. He is the one who can manage the situation. He is the one who tells you what to do and what not to do. On top of that, educate yourself. You need to understand the blood pressure, how to manage the situation, what kind of food, what kind of exercise. So don't be one of those people who develop stroke because of ignorance, because they did not want to follow the instruction. Because remember, I always say, time waits for no one.